Thank you. I have received honoraria from Indivior for participation on advisory boards and for speaking engagements, as well as for sublocade injection training. I get a stipend as well for participating on the Medify Advisory Committee. And in terms of mitigating any of these conflicts of interest, I won't be discussing Indivior products today. So the other thing is I will be talking about off-label use of a medication, which is commercially known as Cadian, or slow-release oral morphine. This has become a kind of a key component in the new guidelines in terms of enabling or enhancing the use of methadone for treating people who use fentanyl. So people are all wondering, I mean, not very many people are wondering, but you might be wondering why we decided to write these new guidelines. And really, this was basically oops, sorry. I've got all sorts of things in my way here. There we go. The rationale for writing the guidelines is one of the things I'll review. And I'm also going to go over some of the underlying principles that guided us as we were writing the guidelines, and how we are basing them so much more now on clinical judgment rather than setting up rules. I'll review some of the key changes, and while I do that, I'm going to go over some of the literature findings that we came across that helped us frame our guideline development. And I'll also be sharing intermittently feedback from our focus groups of people with lived experience who have opioid use disorder and have been on opioid agonist therapy, either in the past or currently, and who helped us to really refine and target the approach that we use to write the guidelines. If I have time, which I hope I do, I'll talk about a case just in the context of some of the changes that we've been recommending. Sorry, I'm having trouble moving this forward. There we go. So I'm working from a government computer, so it works about as well as anything else. So what we started with was a focused literature search of any evidence. Some of the key phrases we used were methadone for people who use fentanyl, methadone initiation and titration protocols, optimal dosing of methadone, methadone safety, and methadone treatment retention. These were all key components of what we wanted to learn, and we achieved consensus among ourselves, shared drafts, shared reviews of each of these pieces of evidence. The guidance document was reviewed first among us as we drafted our first version, and we then invited reviews from clinicians who were working in various health disciplines in addiction settings and different addiction settings, both inpatient and outpatient. We also solicited anonymous reviews from members of the Medify Google group. And we also asked for feedback from a focus group of people who had lived or living experience and their family members. So the underlying principles to writing the new these new guidelines were, we felt that clinical decision-making should promote patient engagement and retention and treatment rather than follow a set of rules that may or may not be relevant and helpful to care of the patient. We acknowledge that the risk of subtherapeutic methadone dosing is substantial. So a patient who gets stuck at 30 milligrams and can't get their dose titrated upwards is at much higher risk of treatment dropout and fatal overdose. Whereas the risks of iatrogenic methadone toxicity are lower than they used to be when it's prescribed appropriately, and much lower than the risk of overdose from street supply of opioids like fentanyl. Of course, we still acknowledge that caution is required because the pharmacology of methadone hasn't changed. Dose increases, we continue to see the same issues of bioaccumulation in the first 2 weeks. But other than that, we wanted clinical decision-making to be based on clinical judgment above a rule book. So we looked at the effectiveness of methadone treatment for fentanyl users. There was a number of studies that were very recent in the last couple of years, and that data included people who were using fentanyl. A couple of studies, one study showed that methadone was actually protective against fatal overdose in a systematic review. It showed the overall mortality rate for people while on methadone was 2.6 per thousand patient years, rising to 12.7 per thousand patient years when people were off methadone. That one was quite significant. There were also a couple of studies which showed that people who who were on methadone before the fentanyl epidemic, let's call it, their relative risk of death when they were not on opioid agonist treatment was 2.1, and that rose to 3.4 if they're off OAT during the fentanyl, when the fentanyl crisis was declared in 2016. And the mortality rate for people who were on OAT and stable on their OAT between 2010 and 2018 remained the same. So the mortality, the risk didn't go up for people using on fentanyl who are using, on methadone who are using fentanyl compared to people who are off methadone and using fentanyl. And in terms of effectiveness, we know that methadone appears to be protective, even for people who continue to use fentanyl. The most recent study was a 6-month study from Rhode Island looking at 127 fentanyl users who were on methadone. They were followed over 6 months. There were no deaths among these patients during that 6-month period. The only deaths were 4 people who had dropped out of treatment. So these are people who are off treatment and not on methadone. We also know that higher doses are probably more protective than lower doses, which is a little bit counterintuitive. I was explaining this to somebody this morning. The risk of fatal overdoses is higher in people whose dose is under 60 milligrams and lower in people whose dose is over 80 milligrams. And this is one study from BC just last year. They've also shown that methadone has higher treatment retention rates than buprenorphine. And this is an important acknowledgement that we need to make. And we find as well that when people are using fentanyl and they're still ambivalent about stopping their fentanyl use, and even when they're not, they may be very committed to stopping their fentanyl use, they still find it very difficult to stabilize on buprenorphine. This is data that's been really consistent for quite a long time. In fact, they were even before fentanyl, they were looking at in Australia at women who use heroin who are pregnant, and they were finding that the retention rate was still much higher with methadone than it was with buprenorphine over 6 months. So some of the conclusions we made about fentanyl were that it confers substantial protection against overdose, mainly because it helps maintain respiratory tolerance, and it still remains by far the most evidence-based and important public health strategy that we have to address the opioid crisis. Now, what I'll do is talk about some of the shortcomings and summary changes that we've recommended that are in the body of the new document. Then at the end, I'll give you the website of the document where we have it posted, for those who haven't seen it already. So for people who use street fentanyl, their opioid tolerance and their respiratory cross tolerance with methadone is high, very high actually, across all opioids or most opioids. So a point of fentanyl, even though you can't really calculate it, is really a point means 100 milligrams, which is about 10 to 100 times the morphine equivalents that we're usually comfortable working with. But the access and the quality of the supply varies hugely, and so the toxicity risk is very high. We know that with methadone, it maintains opioid tolerance from dose to dose. So when people are irregularly accessing short-acting opioids like fentanyl, methadone helps them maintain that respiratory tolerance. We know the doses need to be at least 60 milligrams to really confer some respiratory protection. And we also know that when people are on methadone, the number of injecting events per day, and this is not proven in evidence yet, but it's assumed based on some of the data we are seeing, that it truly is harm reduction. So if people are injecting less often, we know that they're exposing themselves to all the harms that come with that as well. So one of the key things with methadone is we recommend, and this is a little different than the old guidelines, and I say old meaning the 2011 guidelines, is we recommend a maximum possible starting dose. So for us, that's still 30 milligrams, but it's almost never 20 or 25 or 10. It's almost always 30 milligrams. So one question we get is, why not 40 milligrams or higher? We still don't have good data that shows that starting at 40 milligrams and titrating up at the rate that we're familiar with is safe. We still see deaths in the first 1 to 2 weeks of methadone initiation. So that starting dose is still 30. So that really hasn't changed. We also know that methadone metabolism is still, again, hasn't changed. It's still related to hepatic metabolism, that those enzymes have to be activated in the first 2 weeks, and that tolerance really has to build in those first 2 weeks. So despite high opioid tolerance, there's incomplete cross tolerance with methadone. So we can't say, oh, well, people are using 100 times more fentanyl, or sorry, 100 times more morphine equivalents a day. We really should be giving them more methadone. We couldn't say this based on the data we have. We're hoping that in the future, perhaps there will be more data on more rapid higher dose starts and more rapid increases, but at this point we're not. But what has changed is that we're recommending that for people with a benzopositive urine, they should still be started at 30 milligrams of methadone if they're using fentanyl. Even if the UDS shows benzopositive, due to because that's much more likely to happen now. We're seeing a lot more benzo contamination in the fentanyl, and it doesn't necessarily mean that it's putting people at increased risk of death from the combination of methadone and benzodiazepines together. And our recommendation is, again, using clinical judgment, that unless the patient has demonstrated benzotoxicity, for example, showing up in the clinic or at the pharmacy looking sedated, or if they have a very high risk, like if they're a heavy alcohol drinker or significant advanced COPD, or they're very elderly, that the dose should still start at 30 milligrams for people who are using fentanyl. So titration decisions should be optimal and based on the patient, but again, we've created parameters that within which people should be able to feel safe based on the data that we've reviewed. So we suggest titrating the dose by a maximum of 15 milligrams every 3 days, despite benzos in the urine, which is a departure from the previous recommendation where people would sort of be anxious, and we would start at 20 or 25 and increase by 5 or 10 milligrams rather than 15. But for people using fentanyl, unless they're sitting in front of you and they're nodding off in the clinic, or they're intoxicated when they present to the pharmacy, we recommend that you use the maximum recommended as previously recommended. But for people who have benzos on board. For people who are using high amounts of street Xanax, and we tend to see this more with the younger male patients, they should be considered, I would consider lowering their starting and titrating doses. Or people who are describing every day having blackouts after using fentanyl, I would be concerned about the amount of benzo that they're exposed to. But really the point is that we want decisions to be individualized rather than following a set of rules that don't work for everybody. Titration rates can be slower, 5 to 10 milligrams every 3 days, or even holding a dose and not increasing, holding a dose increase when clinical judgment prevails. So if you're very concerned about someone, I do have a couple of patients who will nod off in the clinic and they just keep getting 30, unfortunately, but they are stable and they certainly are still engaged in treatment. As far as restarts go, if people have come off of methadone, if there's someone you know who's been on a higher dose, First of all, someone who's continually showing up and then missing doses and showing up and missing doses, people want to know, what are the strategies for not having those people drop out of treatment? One would be, we recommend an extended prescription. So I will write a prescription when I see someone who's been on and off of 30 milligrams and is missing days of doses, and then occasionally getting 30 because they've come back into the doctor. I'll write them a 1 or a 2 week prescription for 30 milligrams. They can show up at the pharmacy, and the pharmacy knows, as long as the patient's not showing up sedated, they can have a witness dose that day. That at least gives them the opportunity to get more doses in a given week. And I always tell them, if you can get 3 in a row, come in and see me. And actually, based on the new guidelines, we even have a bit more flexibility. You can even consider a scheduled dose increase, 1, between 30 and 45, by writing on the script. So if a patient comes to you and says, no, I absolutely am going to get the next 3 days doses, and if they do get those 3 days doses, you can pre-prescribe the 45 milligram dose increase for people using high amounts of fentanyl. At least get them to that 45 before the following week when you see them again. The other strategy is to offer slow release oral morphine along with the first doses of methadone, and I'll talk a little bit about that. So slow release oral morphine is basically morphine. So it's a full mu agonist, just like methadone is. Always consider adding it when starting or restarting methadone, especially when people who are using a lot of fentanyl, maybe they're using a point or more a day, will say, I can't even feel the 30 milligrams. So one example would be to give them, let's say somebody's using a couple of points of fentanyl a day, give them 30 milligrams of methadone plus 200 milligrams of slow release oral morphine. You can even titrate up the slow release oral morphine over the first couple of weeks, but many people find that what happens is, first of all, the patient benefits from the morphine on the first day. So they're going to get the benefit of that 200 milligrams of morphine over the hours following that first day, whereas they're not going to get the full benefits of the 30 milligrams until the 3rd to the 5th day. So this gives them a bit of more immediate relief in the first few days, and they're more likely to show up the next day and the next day for their 30 milligrams of morphine, because they're going to get something that's going to work more quickly than the methadone. And it doesn't necessarily need to be tapered down. I have found some patients, when they get up around 100 or more of methadone, some of them do fine and don't feel they need the slow release oral morphine anymore. And they actually tell me that. They're like, no, I don't need it anymore. I'm feeling okay again. Generally, I find for patients using a lot of fentanyl, that's not necessarily the case, and I will keep them on both. The prescription should be written as witness dose daily with methadone, open capsules, give sprinkles in cups, swallow with methadone. This is how I write it. There's a number of different ways to do it. It's basically a witness daily dose of slow release oral morphine. And even though the capsules are open, it's still slow release, because the slow release beads are designed to be released at different rates depending on where they are in the GI tract. So we asked our focus group to give us some feedback on these first aspects of our guidelines, and their response was that 30 milligrams is too low to make a significant impact on withdrawal symptoms among people with high opioid tolerance. Their experiences, they tell us, they've had substantially higher doses themselves that they've taken from someone's carries or from a street purchase, and that they haven't overdosed on those extra doses they've taken. And the group recommended that the starting dose should really be between 40 and 60 milligrams. Our response to that was that there will be settings in which 40 may be used as a starting dose, mostly in patients or patients that we know well who've been recently on a very high dose and perhaps missed less than a week, and there's someone you're comfortable starting 40 on. But for the most part, we have to stick with 30 in the community until we have guidance from new evidence that we're hoping to see over the next few years. But our other response was adding slow release oral morphine to the methadone would be a good strategy to augment those first days when the methadone dose feels too low. And at the time that the focus group looked at our draft, None of them had been familiar with being given slow release oral morphine because it wasn't done very commonly as recently as a year ago. So some of the individuals who participated in the focus group have since had experience with slow release oral morphine and tell us that they do find it really helpful. So the question is how high to go. So this was another question we had to ask, because in the past, most of the literature said that for people who use heroin or prescription opioids, 80 to 100 milligrams is adequate and should get most people stabilized. But we found that in the literature we looked at, doses above 100 milligrams are really needed for people using fentanyl regularly, because they're as long as they're not experiencing any sedating side effects, which they usually aren't. We also recommend that methadone dose increases shouldn't be delayed above, let's say 120, 130 if you're not able to get an ECG and they're still having withdrawal symptoms or cravings, or the dose is wearing off. An ECG is still recommended for patients who are on 150 milligrams or more, or who are at increased risk of arrhythmias due to cardiac conditions or QT prolonging medications, or their use of stimulants like crystal meth. In those cases, you should consider adding slow release oral morphine while you wait to get an ECG. There's really no target slow release oral morphine dose. Some people are on combinations. There wasn't a lot of literature that we were able to turn to get data on slow release oral morphine, but there is the Saskatchewan opioid treatment guidelines, which traditionally, those are old, they were written in 2008, they traditionally advise tapering the slow release oral morphine once the methadone dose is therapeutic. However, that was before the fentanyl days, the fentanyl era. And so now we suggest that if slow release oral morphine and methadone are both required to get people to reduce their fentanyl use, then use them both. And again, as I said, you can increase the slow release oral morphine if the patient feels they need an increase in their opioid and they're at 150 milligrams of methadone and there's concerns, or let's say 140 or 145, and there's concerns about their ECG, getting an ECG. So as far as the focus group was concerned, they felt that 120 is a minimum dose necessary to reduce fentanyl use, and that rapid dose escalation is important. It's an important motivator for people to help them get the methadone rather than the fentanyl, which is easier to get. And our response was the titration protocol is a little bit clearer and stronger than the previous one, but it may not be enough to meet their needs, but that slow release oral morphine use more routinely may be helpful to counter that tendency for people to just give up and drop out or not show up at the pharmacy. And we're hoping that future versions will be able to rely on new evidence for more rapid titration protocols. I've just pulled this little table out because missed doses are something that people are frequently asking about, and this has been a big change. It seems like it's little to some people, but it's actually a pretty big change. So in contrast to the previous guidelines, in contrast to previous guidelines, we don't recommend changing or restarting methadone unless the patient has missed 4 consecutive doses. As far as the slow release oral morphine, I won't get into it, but adjustments for missed doses, you can look at the table in the BCCSU guidelines, of British Columbia Center for Substance Use guidelines. They have some recommendations for adjusting slow release oral morphine. The thing with this is that pharmacists are not all going to have access to the new guidelines yet, and you may have to make a call or make a note on the prescription to let the pharmacist know that you know what you're doing, that the patient's missed 4 days and you still want them to get their previous dose. So basically what we're saying is if a patient misses 3 days and presents on day 4, they can continue their previous dose with no adjustment required and continue with 10 to 15 milligrams every 3 days, titrating up. If they miss 4 days and present on day 5, they can you'll have to reduce their methadone dose by 50% of the previous dose, or put them to 30, depending on which is higher. Then give them 10 milligrams daily for the next 3 days, not to exceed their previous dose. So you're trying to get them back to the dose they were on previously 5 days ago, and then reassess and proceed as usual. So there's a number of ways you can do that. If they've missed 5 or more days and present on day 6, we recommend you have to start at 30 milligrams, and you can use slow release oral morphine at a maximum of 200 milligrams. In addition, you can also use slow release oral morphine in the second condition where they've missed 4 days and present on day 5. Again, this is all going to depend on your own clinical experience, your confidence in your judgment, and your knowledge of the patient. So again, for missed doses, you can consider increasing the dose. So when somebody's on a titration and they're missing doses, if they have most of the doses in the previous 5 days, so let's say they got 2 doses, missed a day, and got 2 doses again. This is a typical one where we would have to say, oh, I'm sorry, you didn't get 3 doses in a row. We can't increase your dose today. So there's a couple of ways you can do that. First of all, you can increase their dose on that day because they had 4 out of the previous 5. If they missed the day prior, our guideline recommendation is, and these are just guidelines, our guideline is if they missed the day before, and you're not comfortable increasing the dose the day you see them, you can give them the same dose they had the previous 2 days and then increase it, write the script to be increased the next day. Again, remember, we're being more aggressive here in terms of trying to get people optimized on methadone doses that are going to be effective to reduce their fentanyl use. And always you're using clinical judgment. There are no police that are going to come and check your chart and tell you whether you're doing things right. You're going to know, the more you get experience, the more comfortable you'll be. So I found that when I first started using slow release oral morphine, I started with 100 milligrams, and I explained to patients, you know, I haven't used this before. Bear with me. Let's try 100. And, you know, then they'd come back after a couple of days or the next week, say, it helped a little bit. So then I would try 200 after I was getting comfortable. And there's nothing wrong with, this is new. There's no textbooks that tell us this is what to do. There's no product monographs that tell us this is what to do. And these guidelines are certainly not meant to tell anybody what to do. They're to help you build more flexibility and pragmatism into your prescribing to the patient in front of you rather than to the patient population. We're pretty bossy about the new guidelines for missed appointments. We actually think that it's not just not recommended, we think that it's actually dangerous to stop a prescription if somebody's missed an appointment. So providing an extended prescription until the patient can be seen is very important. It doesn't mean you have to increase the dose if they're missing appointments, but you have to keep them on whatever dose they've last received. You can consider a dose increase without a visit, as I said before, once between 30 and 40. For example, to get someone up, let's say to 45 within a week of seeing them again, that's a reasonable thing to do, or between 45 and 60, as long as they're getting their scheduled doses. They should be seen before a second dose increase. So we're not saying you should prescribe in, okay, in 3 days you can go to 45 and in 3 days you can go to 60. You certainly could do that if you were confident and you have lots of experience and you know the patient well and you know the pharmacist and people can reach you in those windows of time. Once a patient reaches 80 milligrams, don't continue to increase with missed appointments. So that's a whole other issue, which you wouldn't do, but we know from data that 80 milligrams is assumed to be protective from overdose, but just make sure that that prescription gets continued and that there's a way for the pharmacist to reach you to just to reinforce and clarify these decisions, because these are new decisions. These are slightly new guidelines. They may seem minor to some people, but to the patients, to our focus group, being able to go on, stay on the same dose on day 4 was actually quite huge. And being confident that the prescriber is going to let their dose go higher than 100 or 120 was also really huge. And as I said, never stop a methadone prescription for a missed appointment. If they're dosing regularly, communicate with a pharmacy. A couple of us within our first expert group confessed to each other that we have patients we only see every couple of months and they just keep getting 30 milligrams, and there's lots of communication with the pharmacy. And for that, those given patients, they do better than if they have no methadone at all. Sorry, I'm having a little trouble advancing my slides. I have to poke somewhere. There. Yeah, as I said, so work with the pharmacists. They can certainly hold a dose if a patient's presenting intoxicated or if the patient's presented with too many missed doses. But in these first days of the new guidelines, we are sharing them with the Ontario College of Pharmacists, but pharmacists may be unfamiliar. Just make sure that they can reach you and that they know that you weren't making a mistake. Take-home doses is a very popular question and very controversial. When it comes to fentanyl, we suggest take-home doses should be considered with caution and based on a case-by-case assessment. So for people who've stopped using fentanyl and want carries and are stabilizing in other aspects of their life, so they're back at work, for example, we recommend you then apply contingency management, meaning using regular urine drug screens just as we have in the past, perhaps not every week, but and that they not have a take-home dose in the first month of stabilization. And then, of course, for people who have stabilized really well on methadone and are no longer using fentanyl, have fentanyl negative urines, and perhaps they're back at work and they have some social stability and they're stably housed. If they really need regular or many take-home doses, it's worth considering at that point transitioning them over to a buprenorphine option. Now, the focus group, they felt that carries should be provided almost immediately so that methadone is more compelling to them than fentanyl. They also felt that carries are essential for people to work and live their lives and should be based on trust and not urine samples. And they strongly disagreed with the notion of carries as contingency management. That being said, we know historically from data that contingency management actually is effective when we look at people at the population level. We agreed that the decisions about carries should be made based on ongoing evaluation of the benefits and risks for a given individual, but we also have to be considering the risk to the public of possible diversion. So we can't simply acknowledge that whatever, a group of people with lived experience states they would like, we can't necessarily provide that, but we certainly can have more flexibility. We don't recommend initiating carries at the onset of methadone treatment, and the document won't say that, but we do recommend building clinical flexibility. I'm starting to sound like a broken record, but clinical flexibility substantially in these clinical judgment in these guidelines. So related to that is the question of urine drug testing. What I've found, and I'm sure there's some people that have probably found this as well, and that is that for people who are using fentanyl and are still titrating up on their methadone, urine drug testing is helpful when you're titrating if the patient's presenting in some way that clinically doesn't look good, so sedated, for example. So if they're combined with sedation and they have benzos in their urine, then you might need, that might be an effective use of a urine drug test. So for somebody requiring a dose change and there's a history of being sedated when they presented to the pharmacy, for people who've stopped using fentanyl and have achieved social stability and would like to earn take-home doses, then urine drug testing becomes part of contingency management. It's also, I find, helpful for people for their own knowledge. So I will ask patients. So if I have patients who've been actively using fentanyl, maybe they're not motivated to have take-home doses. They don't really mind one way or the other. And I'm sure many people have patients like that. They don't need a urine drug screen. I don't know why. It wouldn't change anything for me, but I will offer it to them. I'll say, would you like me to do a urine test? And we can look at what you've been exposed to or what's in your fentanyl, especially if they're having blackouts. A lot of people are very concerned and want to know what's in there. That's another reason. Sometimes there's a third party request, so someone at work or a spouse, in which case I give the a printout of the test to the patient and they can do what they want with it at their own discretion. But I think it's important for us to remember that, first of all, not all benzos show up on a urine, and not all sedating medications that could put someone at risk are going to show up on a point of care test. For example, gabapentin, there's lots of data that shows overdoses where the only other culprit besides the methadone was gabapentin, for example. And we're not testing for those medications. We're not testing for Seroquel. There's other potentially very harmful medications. And so we're really not being fair by saying, oh, well, if you have benzos, this happens, or if you don't have benzos, this doesn't happen, when we know that the information we're getting from urine drug testing is really incomplete. So the focus group had really strong things to say about urine sampling. They felt that, first of all, that urine sampling should never be supervised. They said it's really important to have an open, honest relationship between patients and providers. And they specifically said we need to stop punishing people who use drugs by deciding that their course of treatment from their urine samples. Those, what we've always considered objective results, which possibly in the past worked very well, but these days don't actually work that well. Our response to that was more or less agreement that urine drug testing should not be required for a prescription to be released, or for an appointment, or for dose adjustment. There's so many limitations, as I mentioned, with urine drug screening. It really is silly because of the amount of false negatives one would expect to see. And that the frequency of sampling should really be between the patient and the doctor. And when a therapeutic relationship exists and clinical stability has been established, really they become less relevant. The other thing that we've mentioned in these guidelines, and I mention this in particular to my patients, is that most of us have patients who don't want to go up too high. So I just want 20, or I just want 30, or I don't want to go higher than 40. And some of them are afraid that the methadone is going to block the effects of the fentanyl they're using. Others are afraid, well, then they're going to have to get off of a higher dose. And these are usually the arguments that we hear. For those patients, I will tell them about the study that showed that people are less likely to die of a fentanyl overdose if their dose is over 60 or over 80. So I'll tell them that 60 to 80 is more helpful and protective for them. If they're still resistant, I'll offer them some slow release oral morphine, because again, this helps raise some of that respiratory cross tolerance that they need to help reduce their risk of fentanyl overdose. And for people still using fentanyl, when they're at 100 milligrams, we recommend continuing to increase their dose or adding slow release oral morphine. And I mentioned ECGs. I think I also already mentioned this for doses over 150. Do get an ECG if you can, but don't withhold a dose increase at lower doses, and consider using SROM or slow release oral morphine if you can't get an ECG for whatever reasons. The overarching principles of all of these new guidelines are to adopt practices which promote treatment engagement and reduce barriers for people to re-enter. So people are less likely to fall off if they know that you've laid them up with a prescription that's going to sit at the pharmacy for the next couple of weeks. It doesn't mean that, it means that this Saturday's dose isn't, the end of their treatment, and that everything's left on them to have to re-engage. The frequency of visits should be based on clinical need and decision-making, not based on a fixed schedule, like not every week because that works for you once they're on a functioning dose. But that we do understand that methadone treatment is life-saving. This is a life-saving treatment for opioid overdose, and it's probably being underappreciated for that on a number of levels. Even by getting people onto methadone so that it reduces the number of ejection events by providing them with an oral opioid is reducing risk and harm. We also recommend people focus more on treating concurrent psychiatric and medical conditions, and connect people with other services and give them naloxone kits and clean supplies. So just summarizing, long-acting opioid agonist treatment is a life-saving intervention. It can reduce the desire and frequency of fentanyl use and injecting events. People who use fentanyl have higher opioid tolerance, but we still acknowledge that methadone has its built-in risks and requires caution. We can't simply prescribe whatever we want, whatever a patient wants. We want to encourage retention and treatment using prescription extensions and expediting a dose increase when possible, giving patients more education around the meaning of being in treatment versus dropping off, engaging with pharmacists more, and also by encouraging treatment reentry and making sure that those scripts get renewed when a visit is missed. So these are all really important strategies that we recommend should be engaged when people are using fentanyl. So we have like 10 minutes. I wouldn't mind getting some feedback. Would people want to ask questions now, or would they like me to do a case? I may not have time to do both. So does somebody, Kathy, are you able to just quickly poll the group, or do people?
Nobody's put anything in the chat yet.
Oh, okay. Because I can start going over, you know what I'll do is I'll start this case. And if there's questions, people are welcome to throw them into the chat and I can be diverted away from the case, but the case will also bring up questions. All right. So we've got Roger's a 50-year-old male. He's been your methadone patient on and off for 3 years, and he's using IV fentanyl daily. He was last stable on methadone without any opioid use about 2 years ago. He's unstably housed. He's showing up irregularly. More often than not, he's missing doses. And today, clinic staff send you a message that he wants to restart methadone. He waited for a little while, but then he left without being seen. He told the staff he's using a gram of fentanyl a day. That's 10 points a day. What can you do for Roger? What I would do, I would send a prescription to the pharmacy for methadone. If Roger's someone I knew well and I knew that he never shows up sedated because he's almost always in some degree of withdrawal, I would be prescribing him 30 milligrams of methadone plus 200 milligrams of slow release oral morphine, daily witness dose for the next 7 days, and have him come see me. Next step, Roger misses day 3. He hasn't made it back to the clinic. He's now at the pharmacy asking for a dose, and the pharmacist calls and asks for guidance. What would you do? Would you continue his dose? Would you increase it? Does anybody want to jump in with any suggestions, or should I sort of carry on? How many times would you extend a prescription for Roger? What's the longest you think you would write him a prescription for 30 milligrams without seeing him in the clinic or doing a urine test? Anybody? Anybody who prescribes methadone in the audience? I have no idea.
Actually, if you look in the chat.
Oh, there we go. Okay, great. So yeah, I have a busy screen.
Sorry.
Great. Okay, no, that's good. What's the highest dose I've seen alongside methadone? 300. What I find is I have people are usually 200 to 300 just seems to be enough to get people comfortable enough that they're less likely to miss doses, and they'll be able to titrate upwards. What I find is when they get their dose of methadone up above 100, the morphine's not necessarily doing as much for them. They may still be using fentanyl and they may still want some, but it may not be as effective for them, and they may not they may not care. So I've had a couple of patients say, oh yeah, no, I'm much better now on 120. I don't really need the Cadian anymore, which is always a surprise because I always think, oh, wouldn't they want that too? But they're probably not getting much of a reward from the Cadian because the methadone is on board, the same way you wouldn't get a reward from heroin when your methadone dose is 100 or more. So for whatever reason, they just don't need it anymore. I have a question from Wendy Wilson about naloxone. Fire away. Hello? No? Wendy, are you still there?
Yeah, I'm still there. I'm just trying to get back in the game. Nope, not yet. There. Nope, I don't know. It just doesn't
We can hear you.
I know. What is wrong with that? That is just so weird. Is somebody blocking the video? Okay, so I don't know, Kathy, if you're blocking the video input. Anyways, so in Perry Sound, Dr. Regenstreet, we have a core group of fentanyl users who seem to have this fixed false belief that, well, I got naloxone, so I can just use fentanyl as much as I want. And, I'm just going to kind of reverse it, or my buddy's going to reverse it if I overdose. So where does naloxone fit in with these methadone guidelines? In fact, that they're not always okay with naloxone, and sometimes they need, many naloxone doses to counteract the fentanyl.
Oh, I see. So I think what you're saying then is where does methadone fit in? That's usually like in an emergency situation, or somebody who's received naloxone and then is seeing you in the office like the next day.
Are you still seeing this? Hey, it doesn't matter if I use fentanyl.
Because I have naloxone.
Yeah.
Oh, I see what you're saying. I'm surprised because most patients have told me that like one kit doesn't work anymore on people.
Mm-hmm.
So, and a lot of times people have been given naloxone and still needed an ambulance. And so they're aware that it doesn't always work. I haven't seen that much, but we haven't addressed it in any way. Like, I just say to people, it doesn't matter, I don't know. I haven't really had that conversation.
Okay. Yeah. Right. It just seems to be like I said, a sort of a fixed false belief in this community.
Is it? Well, I've heard about that. Like I've heard rumors and, a myth about parties where people will take high doses of something and then they'll have naloxone on board. We haven't really heard much about that or seen much about that. So I'm not really seeing it.
Well, it's nice to know that Perry Sound's at the forefront of something. All right.
Yeah. Should I continue with sorry, I got to keep whizzing back and forth to get to the chat. There it is. Is there any more questions in the chat? I've still got like 6-7 minutes. I'll just keep going on this case. And if it triggers any more questions, just like wave a hand. I don't know. There we go. So the answers, you continue the prescription for the 30. I would add 200 milligrams of slow release oral morphine. You see Roger the following week. He took his methadone 30 and his SROM on Friday and Saturday, but he missed Sunday and he dosed again on Monday and Tuesday. You see him, he's alert, he's a bit agitated because you're seeing him on Wednesday. He had 2 days, but he missed Sunday. He says he's barely feeling the methadone. It lasts about an hour after his dose. He's using large amounts of fentanyl still, and he wants a dose increase. What can you do? Well, based on what I've already covered, because he's had Friday, Saturday, and Monday, Tuesday, you can actually give him a dose increase. So you can go up to 45 milligrams plus the 200 milligrams of slow release oral morphine. And that's what I would do. Now, if he missed Sunday and Monday and he came in on Tuesday, there's no right answer. Again, this depends on you and Roger. But if Roger's my patient and I know him well and I know what he's using, what I will do, knowing that he's had a number of doses of 30 milligrams, is I will prescribe 30 for the day I see him and write a dose increase to 45 the following day, because that gives him the 4 days out of 5. But it allows his dose to go up. And patients actually really appreciate these small changes. So then he's back on methadone. He's been on for a month. He's now on 120 milligrams of methadone plus 300 of slow release oral morphine. He continues to use fentanyl, but now he's not using it every day. He wants to go visit his brother in a different city an hour away because his brother was in an accident. There's no pharmacy within 30 minutes of the home where he'll be staying. He's requested 1 carry to make this trip. What would you do? So the key thing here is, based on the old guidelines, you would probably feel confined and not able to give him a carry. You would be saying, I'm sorry, but you're still using fentanyl and you're on all these meds, and I mean, you're on a very high dose of methadone and so on. If you it's again, this becomes up to you. So I would probably give him a 1-day take home. The question about take homes with slow release oral morphine remain. I might give him a take home dose of the methadone, but not the slow release oral morphine. And he may or may not be happy with that. Mainly because we don't recommend take home doses of slow release oral morphine. They're really for people who are unstable and using fentanyl. The problem with slow release oral morphine, and I tell patients is, and some of them already know, that Cadian only dissolves in a cold water solution. So when people open the beads and dissolve them, they can't heat it. So what they're injecting is a cold solution that's non-sterile. And so we've seen some really nasty infections and sepsis from Cadian injections, and in fact, some candidemias, which are really hard to treat. So I am not a big one. My standard is I don't give take-home doses for Cadian. That being said, I have one patient who's a below knee amputee who gets a take-home dose on Sundays because the pharmacy that's across the street that's wheelchair accessible to him and easiest to get to is not open on Sundays. But that's the kind of situation where it's really a doctor-patient context that helps you make the decisions. This is our team that worked on and wrote the guidelines and helped work on the review panel and people with lived experience. Their names are all listed in the actual document itself, which is available on the Medify website. And I'm just going to take one last shot at advancing the slides. And that's Yellowknife again. And this is the website, medify.ca, that has a ton of resources. Most of you, my guess is, have seen this website or have accessed resources, but ours is posted. So this whole document is posted on the website. It's really meant to be the first of a series of documents, and we're hoping to do some subsequent modules on the use of buprenorphine for people who use fentanyl, and the use of slow release oral morphine, and addressing people in pregnancy and so on. So that's it. Should I stop sharing? I think it's actually, there's Wendy.
Hi.
I'm just going to check the chats. I don't think I see any more questions. Anybody? I'll just sit here for a few minutes if anybody has any more questions, and then either Wendy or I will, or then Wendy and I will just sit here and do lunch. No, I think you have to go as well.
I was just thinking how much addiction treatment has changed since, we finished medical school, and how much more humane it is and evidence-based. The former guidelines from the College of Physicians and Surgeons, in order to prescribe methadone, it almost seemed like, you were drinking the Kool-Aid too. And the physician was treated like a criminal. You had to get criminal record checks every year. Your practice got audited on a very frequent basis. And it was all about the guidelines, not about the patients and not about your relationship with the clinicians. So I think this is really exciting.
That's a great point. Thanks for saying that, because that's exactly what this was meant to be. It was to start to take down a little bit of that, that patriarchy, or that really it wasn't making sense anymore, and it wasn't working for our patients. And we were losing more people to overdose because they'd left treatment. And that was really frustrating and hard to watch. And
losing providers because they got frustrated with the guidelines.
Yeah.
And the censor
and not being
from the
able to look
college.
after people anymore properly. Yeah. Yeah, great point. Very quiet audience. Is there anybody there who works in a RAM clinic? Does anybody know? Anybody there knows how to use the hands up? Raise hand. Yeah, I know you guys have one up there, and I figured some of you'd be there. And I'm guessing that you guys use the Google group, the listserv.
Yes,
do you use the listserv? Yeah,
yes.
yeah.
It's really quite good. We've gotten some really excellent feedback from it, and practice changing guidance. We really appreciate it.
Yeah. It's been great to work with people with experience as well. Like I've been bringing, in addition to the focus group, a lot of us have brought back stuff to our own patients and said, what do you think about this? And, you could gauge, like people would give us feedback as we were writing them. I was like, okay, we're going to try the 100 milligrams of slow release oral morphine. It's not written down anywhere yet. So, but I knew that the Saskatchewan, we had looked at the Saskatchewan guidelines and they had recommended using slow release oral morphine early on in those first days. And it totally makes sense because morphine works on day 1. Methadone might not work till day 3. I mean, even then, but that 30 milligrams isn't really 30 milligrams until day 3 to 5. But the 100 milligrams of morphine is 100 milligrams of morphine on day 1.
I have a question.
So,
I have a
yeah.
young lad that he's a fentanyl user, IV. And we've got him on Suboxone. He's currently at 24 and still having withdrawal symptoms in the form of pain. Would you add a slow release oral morphine?
Not for Suboxone. Great
Okay.
question. Thanks for asking that question. That's a really good question. Mind you, I have done that with 1 or 2 people. I did have a patient with chronic pain, and we did that with him when he was on Sublocade. How old is this patient?
He's 18.
Oh yeah, it is young. Yeah, we're not, and I guess he's technically eligible for Sublocade. What happens if the Suboxone's higher? Have you tried going any higher with the Suboxone?
We just increased it
to 24.
24.
You could go to 32.
Yeah.
I'm sorry.
We're on that path.
You're on the path. Yeah. So try going up in the Suboxone dose, because if it's withdrawal mediated, like he's getting pain when the Suboxone's wearing off, that could be it. I have used Cadian. It depends on what kind of pain it is. Like if this is a chronic pain syndrome, or if this is pain from withdrawal, it sounds like it's pain from withdrawal. I would just go up. I would go up.
Okay.
The highest I've gone is actually 40 milligrams in a slightly older patient, a patient in their 20s. That patient wanted to be on Sublocade, and with Sublocade, you just go as high as you want to go. The fact that he's on Suboxone is really reassuring. Like it clearly means he's in the right place.
Mhm.
Just keep going. Yeah. Suboxone, remember, has a plateau effect, but I think there will be more data coming out in the next year or 2 around, buprenorphine and in people who use fentanyl. And we're kind of hoping to write that piece a year or 2 from now when there's a bit more of that data out.
Excellent. Thank you.
Yeah, great question. Well, I've got a couple more minutes, I suppose, and then I'm going to have to run. Get back into my garb.
So if nobody else is going to ask a question, I might as well. So we're considering doing methadone in our little RAM clinic. We're a very small, underfunded RAM clinic that works 2 half days a week. Where would we start? Will we start at the guidelines and maybe do 1 patient, or should we do a rotation with another practitioner?
So good question. So you got 2 half days a week
And 2 practitioners.
that you'll have, and 2 practitioners. How keen are those 2 practitioners being available on other days to the pharmacy?
Yeah, yes, they're fine.
Okay, because this is what I do. Yeah. So I would try it with a small number of patients, like 1 to 3 patients. 1 might not be enough, because like that 1 person, who knows, maybe it doesn't work for them, but they're people that you want, that the Suboxone's not working for them. Buprenorphine, it's just not. They're like, nah, it makes me sick. I miss a day, and then I use, and then I go and I take my dose, and it makes me sick. And just like, and I tell people, Suboxone and fentanyl are not friends. They're never going to be friends. So what I would do is start with a couple of them. You can time it, or what are the days of the week, just out of curiosity?
So for Monday afternoon and Thursday morning.
So that would work because they'd dose on Monday, they'd see you on Thursday, and if they don't miss any doses, they get a dose increase on Thursday. So there's no
Yeah.
reason why that can't work. You just want to be careful you're not feeling overloaded. And really the pharmacy, I think we underutilize the skills and the fact that the pharmacy is there every day.
Yeah.
Now, I mean, I have a pharmacy that contacts me by text message on a Sunday morning, but fair enough. Not always, but I mean, I have more than 3 patients. I think you could do it. I think you need to just have a plan B. So what's going to happen if I don't know, if it's not working? Like, is there somewhere else they can get the methadone? You don't want to put people on methadone and have to say to them, I'm sorry, I can't do this anymore. So
Okay.
if there's another option for them, or if you could set up an OTN type visit with them, with someone somewhere that supports you, like, I don't know, Sudbury maybe, or, like, I think maybe talk to someone, a provider in Sudbury. Maybe you could get like that backup. There's a RAM, there's at least one, right? There's one RAM in Sudbury, I think.
Yeah, we have a person that we know that just started there. So.
And do you have staff in the RAM on other days of the week?
In our RAM, no.
Okay, so you're just open when you're there and not open when you're not there. Okay,
Yeah.
so they still should, or yeah, it would still be good if they could access somebody. I think the pharmacy, though, you can let the patient know well in advance, like just let the patient know, you know what, we haven't done this, we're going to try this. If it doesn't work, this is what we're going to do. We have plan B, and that could be using OTN with somebody in like either Sudbury or, I don't know, Toronto or something. I know
we have an OATC here in Parry Sound with the methadone clinic.
Yeah, that could be your backup, but ideally it's nice because I'm kind of biased. I think that RAM clinics generally have a bit more to offer. They have a different volume. There's a different culture than OATC, right? So, without stepping on any toes, I just think ideally that person should be able to do that with you. As long as you guys have the training, the methadone training, and I don't see why it would be a problem. I mean, I go into I have a clinic 1 day a week, not my RAM. Well, I work at the RAM 1 day a week, but forget the RAM. My methadone clinic, I only go there 1 day a week.
Yeah.
And a lot of those patients, they're not seen or heard from the rest of the week. Just the pharmacy will contact me. So if you have good pharmacy relationships, and I think you do because it's a small enough place, there's not a ton of pharmacies, I think you could do it. I don't want to like go rah and then,
So
have you get mad at me.
What is the methadone training that you're talking about?
Oh, so you can do the online. Well, CAMH used to offer the course that we did.
Yeah.
You need to know how methadone works. Like you have to, I mean, there's no rules about prescribing methadone that I know of right now, like the college. Are you a nurse practitioner or a physician?
Yes. Nurse practitioner.
So I would do, and we get, as far as I know, the nurse practitioners are supposed to do, there's an online course through BC. Check the CAMH website and see where they're directing people. Okay. It used to be offered through CAMH. I don't recommend prescribing methadone if you don't have experience with it. It's a little bit like warfarin, for example. You know how we used to have to mess around with warfarin, do INRs on people? It's not a straightforward medication. You need to know about drug-drug interactions. You need to know about metabolism. There are people who don't metabolize it the same way. You need to know how often someone needs to be assessed, that kind of thing. So that's why we're still really bossy about methadone. Like we'll say, oh yeah, sure, we would love to give the focus group whatever they want, but there are particular idiosyncrasies of methadone that we can't quite get around. So I would start with the training and make sure you feel comfortable with it first.
Okay.
And maybe do an observership with somebody, like ask OATC if you can come in and sit and watch them looking after a couple of people. That's what we've always done.
Perfect. Thank you.
Welcome. All right. Well, I better go. I think I don't know if there's even anybody, let's see. Oops, we'll stop our screen share. Am I still screen sharing? No, I'm not. Okay. Well, I'm going to end the meeting then. I don't know who else is, but I've got to go see some patients now. Thanks for all the great questions.
Thank you so much.
Bye.
Bye.